Welcome back. Your host, Alencia Johnson.
How we doing? We doing good? Oh, y'all are hungry. That's why the energy's low. Okay, well, lunch is so good as it was last year, as you can smell it. But we have one more really important panel before we get to lunch. So can y'all hang with me? Yes. Can I get a little more energy? Can y'all hang with me? Okay. As we mentioned earlier, we are going to be talking about health. And so the future of health, there needs to be a business case. So presented by Xavier Ochsner College of Medicine, please welcome Dr. Reynold Verret, President of Xavier University, Dr. Leonardo Seoane, Founding Dean of Xavier Ochsner College of Medicine and Executive Vice President and Chief Academic Officer of Ochsner Health, Dr. J. Nadine Gracia, President and CEO for Trust for America's Health, Mary Stutts, Chief Executive Officer of Healthcare Businesswomen's Association, and our moderator, Dr. Aletha Maybank, President and CEO of Novellawells. Give it up for our panel.
Good afternoon, everyone. All right. Ooh, yes. We are between lunch, right? Y'all are ready for lunch soon. So we'll make sure we get into this conversation pretty quickly and make sure that you all have a chance to eat and talk. And the energy so far this morning has been absolutely fantastic, and just really appreciate everyone's presence and the energy that you are giving us as panelists. So we are entering this conversation, the future of health. We could have so many different ways. There's so many things about the future of health at this particular moment that we could talk about. But today, and at this moment, we're going to talk about the business case. And I will honestly reflect, for me, I'm a person, people who know me, of value, justice. We do things because they're the right things to do, right? Morally, we are to do this. We should observe the dignity in each one of us and honor it and do it in all that we do. That is my belief, right? But clearly, that's not the belief of everyone, or else we wouldn't be in this point of this country right now. Also, the ethical imperative also speaks to me as well in terms of doing this work of health equity and health justice, because I'm a physician, right? And we talk lots about, and we've been trained on the code of ethics, and we are supposed to do things, and we have an obligation to do things that are right and to correct wrongs, prevent harm, prevent exclusion. So there's this ethical imperative. And so when I started to learn, about this business imperative, I come from public health. I'm about neighborhood and social justice and social work, but this business imperative, challenged me a little bit, because I was like, well, no, we're supposed to do these things. But then I'm learning, the reality is that we have systems and institutions that don't always believe the things that we believe that are really important for us. And so this conversation is really to illuminate why the business imperative is important for us as leaders of businesses across this world, and for the patients and the people that we serve. And so first I'm going to start off with Dr. Seoane and Dr. Verret. And before we even get to the business, we're going to speak to the historical imperative, right? And it's very intimate to me. I come from an institution, my most recent institution. Its history very much is known. American Medical Association, this is known information, excluded Black physicians for over 100 years from being members of that institution. Also, they commissioned a report to be done in the early 1900s called the Flexner Report of 1910, that ultimately the recommendations ended up closing 5 of the 7 med schools that existed, leaving Howard and Meharry. And so you all are at this moment now of where you're now in this present modern time. It will be the 5th in this present modern time, historically Black medical college that will be opening. And so I want you to speak to that context, and what does that mean for you? What does it mean for your institutions? What does it mean for business as well? And we can talk about more business as we move on, but I just want you to reflect on, what does the historical imperative mean at this moment in time?
People may not know, but there was one of those HBCUs was in New Orleans. So we will not be the first HBCU medical school in New Orleans. It was one of the victims of the Flexner Report. But if you look around and look at, we had a nice segue earlier when they said there's a true physician workforce crisis in the United States, and it's up to 86,000 physicians short, heading in the wrong direction. And when you look at the impact that has in communities, especially minority communities, it is physicians who from those communities who actually go back and practice in those communities. And it's the HBCUs that train the majority of Black and brown physicians for the United States. So Flexner has a long tail to the impact it's done. I mean, it's been over 100 years, right. And yet that impact is still felt in the United States. What starting a new HBCU and the fifth HBCU does is start to reverse that process. And it really strikes home even more when you think of the impacts that also been mentioned earlier today of cutting the grad plus loans, making it more difficult for first generations, people from low income to be able to become a physician, the more barriers that they put out. HBCU medical schools are that shining light on the hill to say, look, we can do it, and we can do it together.
Well, I would add that not only Flexner report, but also the legacy of American medicine has also presumed certain attitudes towards certain groups as well that are incorporated into how treatment is delivered. For example, metrics on hypertension, metrics on neurological baselines, metrics on blood on diabetes and also basic clinical laboratory standards that are adjusted because there are certain assumptions about African Americans that still are rather resilient and remain even though they are not fully scientifically based. It is important that in the rooms that make the decisions about how care is delivered, how care is innovated, that there's representation broadly across what looks like America, and this is actually where we are now. And I think what we will find is that there's a business benefit, there's an efficacy benefit for the society as we provide that care broadly.
Thank you. Thank you. Nadine, with Dr. Gracia. We're friends, so okay, we're friends, we're fine. Thank you. Sometimes you make that mistake, right? So I've known you my entire career, really. When I first started the Office of Minority Health in Suffolk County a long time ago. And you were in a position as well in the federal government at that time. And you're somebody who has at certain times had the word minority in your title. So what does that mean for you at this moment when you think about that? You're now at this credible, large think tank that has lots of influence around policy. Can you just reflect a little bit on that for us?
Thank you. Well, thank you for the conversation, and many thanks again to Dr. Maybank just for facilitating us having this conversation. Absolutely, she deserves a lot of praise. So what she was referring to is that prior to being at Trust for America's Health, I was the Deputy Assistant Secretary for Minority Health and Director of the Office of Minority Health, long titles in DC, at the U.S. Department of Health and Human Services in the Obama administration. And, many of us come into this work, we have professional interests around how we advance health equity, how we end health disparities, but we also come with a story. And for me, it's really my personal story. My family and Dr. Verret and I were having some lovely conversations behind the curtains there. It originally comes from Haiti, and I'm the first generation that's born in the United States. And I know the incredible courage as well as the sacrifice that my family, my parents in particular, made in coming to the U.S. to leave their homeland to create better opportunity for us. And when I was young and growing up and in college and beyond, saw when you see that there are breakdowns in systems, when there are inequities in systems, that not everyone has these opportunities. They don't have ladders of opportunity. It became more of a motivating force for me. So when talking about issues around whether it's the health of communities of color or advancing health equity, yes, it's a professional journey that I've had, but it's the core essence of who I am. And so when I think about moments like these, which are deeply challenging, we know what's happening in Washington, D.C., and the debates and discussions around diversity, equity, and inclusion, and health equity and beyond. It's understanding who are you and what are your values. And I say to myself, who would I be if I didn't continue to uphold the values of equity so that everyone has the opportunity to reach their full potential for health, everyone has the opportunity to thrive.
Thank you for that. And thank you for your work and service as well. Mary, I met you early in my career at the American Medical Association. You've always been a fantastic support and a voice in this space. And can you speak to, so you interact with I think you said over 200 corporate entities across the globe. In the last couple of months, what has been the reach out to you, and in that speak about the work that you do too and the mandate that you have, but what has been the reach out to you as it relates to anti-DEI rhetoric, and how are these corporations responding at this point in time?
Yeah, thank you so much, Aletha. And again, thank you for the invitation. It's my first time at the Essence Festival. I am so excited. But I will get to the point. So I have worked my entire career as a corporate executive for Fortune 500 companies. I've worked for Genentech and Bristol Myers Squibb and Bayer, but also, until that's on the biotech and pharma side, but also on the provider side. Started my healthcare career at Kaiser Permanente, and also I was the first Chief Inclusion Health Equity Officer at Stanford Healthcare, and I also worked at United Health Group. Okay, I get around. But the interesting thing is I became the CEO of the Healthcare Businesswomen's Association about 2 years ago. We are a professional association. We have over 200 corporate partners, and they come to us for us to provide services for their workforce. We are in over 80 countries, and those corporate partners represent a workforce of about 5 million employees that we are able to impact. The HBA is very much focused on providing leadership development. We are also focused on closing the women's health gap. As you may have read, McKinsey says it's a $1 trillion gap, economic gap between women's health and men's health, because of women being so excluded from things like clinical trials and not having the appropriate data for disease management. And we also are very focused on funding women innovators. We know that the majority of the health equity innovation is coming from women who have worked their entire careers in healthcare, so they kind of know what needs to happen to create the innovation, but they are not being funded at the same rate as men. Women only get about 2% of venture capital funding. So at the HBA last year, we held our first pitch competition where we brought these women innovators together and actually gave them funding to continue to do their work. And by the way, the data shows that if you, the most innovative and impactful women innovators are Black women. If you give a Black woman $1, you will get $7 back. And not only that, but the data also shows that when women have their own, Black women have their own businesses, they give back up to 90% into the community, into their family. So brothers, y'all got to catch up. Okay. And then the other focus for us is on developing the healthcare workforce of the future. So I'm sure you've tracked, we are headed for a massive healthcare workforce crisis by 2030, in the next 5 years. We do not have, so we've had 5 generations in the workforce, especially in healthcare. The pre-boomers are still working because they're healthy and they can, not necessarily because they need the money. I worked at Stanford. You got 80-year-old doctors, nurses still riding a bike to work every day. So pre-boomers are still working because they're healthy. Boomers are still working. And then you have Gen X, Y, Z. Well, you know, boomers and pre-boomers can't work forever. You know, we are going to start retiring, but we do not have the trained, skilled workforce to replace them, not just physicians, I mean across every area. In pharmacy, for example, we are in dire straits for science, and we're finding that, as you all know, women are the majority of the healthcare workforce. We are up to 80% of the workforce here in the US. Women are up to 70% of the healthcare workforce globally, and we are 90% of the caregivers, paid and unpaid. Can I get an amen, sisters? We're taking care of everybody. So I always say, if women are not healthy, the whole world is at risk of not being healthy, because we are the majority of healthcare. But we do not have, young women are not opting to major in healthcare fields the way they used to. That is a real problem. So our corporate partners have asked us to address all 4 of those things that I just talked about. That is the focus of our work. So doing work to get young folks involved, interested in healthcare earlier, and my point to them, we can't wait till they're in college because that's too late. We have to get to them in middle school and high school. So we're putting together programs to do that. So that's a little bit about the HBA.
Thank you for that. Thank you for the work. And to build, thank you, yes. To build on that, and coming back to the new med school and the students in the workforce and business, you know, we went to med school, right? We did, well, we did. Did you, did we? I don't know, I did, sorry. I went to med school, many other people did. Health professional school overall. Point being is that we were not trained on the business context of anything, really. We were not trained in business. So I'm curious, you know, in the financial system and investment, and what does that mean? We were not trained on healthcare as a business. And so as you are now thinking about this new school, what will you do differently, potentially, that helps support students in the workforce? And then speak to you more in depth about the business imperative of what Ochsner and Xavier Med School will do together.
I'll start. I did go to med school. I'm a pulmonary critical care doc by trade. I think it's true. I mean, the science and knowledge has expanded. Science is not an ideology. It is truths. And those truths have grown, and we are tasked to teach our medical students those truths. But there's a lot of things in there like leadership, like social responsibility, like business, that are not in the med school curriculum and need to be a core component of the med school curriculum if physicians are going to be leaders. And if you look at our vision statement for the Xavier College of Medicine, it's to train physician leaders for the U.S. So I think that's going to be core into the curriculum. But I will say there's another impact, business case of why we need more HBCU med schools. Let me bring it back to what a message you've heard multiple times already this morning, and that is that we have a physician workforce crisis in the United States today that is heading in the wrong direction, is getting worse. And if you look, for those who are familiar how you train physicians, you go to medical school, and when you finish medical school, yes, you're an MD, but you can't really do anything. You can't practice medicine. You have to do a residency and an internship. And for the incoming interns, and that goes through something called a match, which is an algorithm that puts graduating medical students into their residencies. And for this last year's match, incoming interns, those who finished medical school, 25%, 1 in 4, trained outside of the United States. So we are dependent on a workforce outside the U.S. Why is that? We don't have enough medical schools. And we certainly don't have enough HBCU medical schools. And so I think on that business case of an HBCU medical school in your community, a community like New Orleans, it has an incredible economic impact. There's a real halo effect of having a medical school in your community. And that halo effect leads to jobs. And in fact, when we looked at it and did some of the analysis, for the greater New Orleans area, when the med school is up and running and graduated doctors and doctors are practicing in our communities, it's $125 million a year economic impact for the community.
I would just add one other piece that's important for us as well, is that if you think of what the United States lead in the world, not only as a major power, but also as an economic power, it's also our capacity for innovation and in research, biomedical research especially, that biomedical scientists who are coming out of institutions like Exocom and other medical schools as well are the creators of an industry which has the United States relied upon. But also that makes us healthy as well. That's an important piece. That talent we have to educate. If we leave that talent uneducated, untrained, we do it at our own peril.
I think it's really important to add to that, Aletha, you know, and the data and the work that we did around health equity and improving that. We found through the AAMC that physicians who trained did their residency at the HBCU medical schools actually had much better patient outcomes and did more to address health equity. A big part of that is because they were comfortable being around diverse people, and they understood the cultural norms, for lack of a better term, which I think is just even more. And it wasn't just Black physicians. It was any race physician who did their residency at the HBCU medical schools actually had better performance as physicians. So there, you talk about business imperative and why DE&I is still important. We have so much data to prove that this is necessary work we have to continue.
That's right, and we have lots of data around a lot of things, right, and even what we understand around health. And this, to me, is always a conversation more so about will, and what are people willing to do and not willing to do, not a question of do we have enough data to demonstrate that there's a business imperative to this work. Nadine, can you speak to what you're doing now in terms of at the trust and how that impacts the knowledge around economics and business for communities and policymakers?
Absolutely, and I appreciate that Mary closed with data, because our organization, we're a public health policy and research and advocacy organization in DC, and what we do is advance policies that are based on the data and evidence to inform policymakers, Congress, the White House, the federal agencies on how to improve health and well-being for every community. When we talk about these issues in that intersection of health and business, you can say it succinctly that good health is good business. It's interesting, there was a business leader who said years ago, he said, when our employees leave, they join their families in their communities. So if their communities are not designed such that they promote health, where they don't have, for example, access to affordable and nutritious foods, or where the air quality is poor, the housing quality is poor, then that is not going to help us as a business to thrive. There is indeed a moral imperative. There is an economic imperative. There's also a national security imperative for us to be the healthiest that we can possibly be, because as we look at the number of crises, whether that's the rising chronic disease crises of diabetes and heart disease or cancer, to the mental health crises, to infectious disease outbreaks, when we used to talk about pandemics being just every 100 years, and yet we're seeing the numerous outbreaks that are happening, to then the climate and environmentally related disasters, extreme heat, hurricanes, sitting here in New Orleans and reflecting on Hurricane Katrina and its enduring impacts. We have to understand how vitally important it is that we bring these sectors together. What we do in public health is think about those broader community conditions, because when you have healthy individuals, you have healthier families, you have healthier communities, that's a healthier workforce, to then work in businesses, to have greater productivity, to be able to reduce absenteeism. And so businesses really play a vital role to actually help shape the conditions in communities and to be a partner with public health, to be able to promote these types of policies and conditions to assure that we can continue to thrive. The U.S., we spend the most in terms of our annual health spending of all high-income countries. We spend more than $4.5 trillion a year on health spending, but our health outcomes don't show for it, right? Our life expectancy is the lowest. When you talk about women who are dying while they're pregnant or immediately after pregnancy, we have the highest rates of maternal mortality, and Black women, even higher rates. Children that die in the first year of life, babies that die in the first year of life, we have the highest rates, again, as a nation. But when you talk about that $4.5 trillion, less than 5% of it is going to public health and prevention. To be able to make, yes, I heard some audible gas, less than 5%. And so what we need to do is really walk the walk of saying we can be a healthier nation. That's something that we at Trust for America's Health do. We have partnered, for example, with the Health Action Alliance to walk the walk of a large network of employers that are making that intersection between public health and business, and then educating our policymakers about when you invest in prevention and public health, there is a return on investment. It makes us healthier, it makes us safer, and it allows us to thrive and be more prosperous as a nation.
Thanks for that. That was a lot of great information. I didn't know one piece of that. So good to know. And I think that's a whole other conversation around public health and healthcare and the need to bridge that particular gap. You know, that's one of the opportunities from being at the American Medical Association, I will say, of being able to see the ecosystem of health, not so much from that point of view, but because I was also in the New York City Department of Health prior to that in public health most of my career. And I was shocked actually, when I got to the healthcare side, of the complete disconnect. And it showed up for many folks, as we know, especially during COVID. Well, we're still in COVID, but understanding the heights of COVID and when people were really ill and sick and passing away in this country. But we need to really find ways to do that as well, this public health, healthcare divide. So we only have 40 seconds left. You see me looking at the, and I know y'all want to eat. Can you, like in 1 word, 2 words, 3 words, like short sentence, what would you say to business leaders who are listening in, who are in the audience, health leaders? You know, what would be your advice in terms of, you know, really capturing and understanding this business imperative at this moment in time?
Look, it's hard not to reflect on what is going to happen tomorrow, which is we're going to celebrate our independence. And when we declared that independence, there was unalienable rights of life, liberty, and the pursuit of happiness in there. And I would argue that you cannot have life or pursue happiness without health and wellness. And so it's at the very core of what we are and how we exist and how we can thrive as a business, as a community, as a nation. And this linking public health with health care really is that linking of life and the pursuit of happiness.
Invest in the talent of our young people and educate them so they can serve.
I would say one is use the power of data to better understand the health and needs of your employees, but don't stop there, because health doesn't just happen in the company, it happens in the community. And then become a partner with community organizations, with public health and other sectors to leverage your voice and influence to the decision makers, the policy makers, to make those conditions ones in which everyone can thrive. When we talk about policies like paid sick leave, which we know that, for example, Black workers have a less likelihood of having paid sick leave, how critical that is to assuring retention, recruitment, and actually economic gains and benefits for businesses. To also thinking about opportunities like livable wage, to assuring that people have the conditions that actually promote health. Your voice is incredibly powerful, and doing so in partnership with other sectors will truly help us to thrive.
I would say meritocracy is a three-way street, so that's the new term, you know, for DE&I. You ask me what the companies are asking us in terms of DE&I. So none of our companies have asked us to stop doing anything that we're doing, but they have asked us to talk about it in a way that lets them continue to maintain their federal government contracts and other things. So, but what is okay, quick, she said. Meritocracy is a three-way. So people are saying that now. That's the new thing, that everybody merits. So first of all, merit has always been, okay. Employees merit. Employees have always had to merit their jobs. That was table stakes. That's insulting. We've been overqualified. We merit the jobs. Secondly, companies have to merit these employees continuing to stay there and work for you. They don't have to stay there. And most importantly, patients merit more than just our innovation. They merit better health outcomes. They merit us ending health disparities, and they merit the chance to live the life of their dreams.
My mic, okay. So thank you. Thank you, everyone, for you all. There's a lot of people still out there. I appreciate it. And thank you for your brilliance, your leadership, especially during this time. It has been hard, I know, for many of y'all. So thank you, and thank you all for listening in, and enjoy lunch.